Okay, now we're going to switch gears. And again, my name is Christopher Gross. I'm at the Medical University of South Carolina in Charleston. And I'd like to, again, thank Dr. Parekh for allowing us to participate in this event. The Parekh Family Foundation and the Global Town Hall, this has been excellent. And Selene, you're almost there. So it's my pleasure to introduce the speakers for this presentation, which is going to concentrate on neuropathic trauma. So Dr. Amgad Haleem is at Oklahoma University. He's going to be speaking to us about just general tidbits and tricks, pearls about treating the neuropathic trauma patient. Clayton Bettin at Campbell Clinic, who has extensive knowledge in midfoot trauma, specifically in the neuropath. My partner, Dr. Daniel Scott at the Medical University of South Carolina. He's going to be talking about neuropathic ankle fracture treatment. And then we have Dr. Benjamin Jackson at USC, the real USC in South Carolina, where he is currently a professor of orthopedic surgery, and he's going to be discussing his good, the bad, and the ugly. And if we have time, I have a lot of cases to discuss with them. So without further ado, Dr. Haleem.
Thanks a lot, Dr. Gross. It's an honor to be here. And I'll keep it short and sweet. I just want to focus on the general workup. A lot of us, when we see the neuropathic fractures, get a little bit frustrated. We don't know how to manage them. We don't know how to work them up. So this is just a basic talk of tips and pearls on how to manage these. So fractures in neuropathics are very common. They can present acutely, subacutely, or chronically, as we all know. They include many areas of the foot or an ankle, either alone or in combination, which increases the complexity, and this can definitely be complicated by the soft tissue compromise, as we can see here. Even if you do not electively treat Charcot or neuropaths in your practice, neuropathic fractures will see you, and you're going to end up taking care of them. So the whole, again, idea of this talk is just to take a deep breath and be comfortable formulating algorithms of management of these patients. I think the slide advancement is a little bit slow on my side. Most importantly, you should be more comfortable ordering the basic workup for these patients and not be hesitant to send them to the IM team or the internal medicine team. Although we left medicine in school, as I said, that yet not everything is like reading an AKJ for orthopedic surgeon when they quote as it is a double-blinded study. So I think we can decipher the labs on these patients and make it a little bit easier. So my tips and pearls. Number one, do not wait to optimize your patient. These are not elective cases. If they present with an acute fracture, then please treat it as you would treat an acute fracture. You will get all these labs and still order them, and you will optimize the patient, but you're going to optimize them while they're in the hospital, getting ready for surgery and after the surgery. Do admit them straight away, and this is the usual panel that I typically order. So it's basic. Again, the basics require an interdisciplinary team. If you don't have one in your practice, then you should definitely establish one. It's easier for those of us in academic institutions where we have multidisciplinary teams. But if you're in a private practice, in a hospital, a community hospital, definitely seek help from an internist, a cardiovascular medicine attending, an infectious disease doctor, a plastic surgeon. Case management should definitely be involved with or without a nutritionist if you have one, and an orthotist and prosthetist. When it comes to the workup, again, the clinical exam is optimum. A lot of these patients are going to present to you with acute fractures and tell you that they do not have neuropathy. I always say the Nile is not a river in my home country, Egypt. It's a mental status of the diabetic patient. So always check for macrovascular disease, palpate the pulses. If you do not feel pulses, send them for ABIs and TCPO2s, transcutaneous oxygen pressures. If you cannot palpate pulses, then definitely get a cardiovascular medicine consult for these non-invasive studies to be followed by a CT angiogram. And a lot of times the cardiovascular medicine docs are going to be able to do a cardiac cath, a peripheral arterial cath, and revascularize these patients for you. However, a lot of these, and we've been told that the neuropathic foot is a hyperperfused foot, but still, despite pounding pulses, you can still have microvascular disease. And I've had patients that I operated on that were neuropaths with pounding pulses, but they still developed a little bit of ischemia post-op. So beware of the microvascular disease. Always check their neurostatus with a 5.07 monofilament. They're sold by the dozen online. Keep one in your pocket, and if you see a diabetic patient, not necessarily neuropath, make sure to test them and make sure that they don't have neuropathy. You'll be amazed, the recent trauma literature, this is out of our friend Stuart Cooper. In the old days, we used to get away with an 8% for hemoglobin A1C. This paper out of FAI showed that the hemoglobin A1C less than 7.5 was associated with more favorable outcomes, and postoperative infection was higher when we surpassed the 7.5% mark. So I think, although we always stick with the 8, I think now the new literature is pointing to 7.5 on the A1C. Another very interesting study found the prevalence of vitamin D deficiency to be extremely high in neuropaths and diabetics. Almost 50% of them are going to be deficient, and almost 1/3 of them are going to have some sort of vitamin D insufficiency. So it's part of your routine workup to order vitamin D, and if you don't, then please put them on vitamin D post-operatively. Always check their comprehensive metabolic panel, as diabetic kidney disease was found to be associated with increased complications following operative management of these ankle fractures. So if you see elevated kidney functions, do counsel the patient that the results are not going to be optimum. Again, something that's routine and we've been tested on our exams here in the US with our residents. Always check the nutritional status, get serum albumin, total serum protein. I do not advise giving these patients albumin acutely. The albumin has a very short half-life and it's not going to help you, but get a nutritionist involved and try and control their diet and put them on a relatively high protein diet if their kidney allows them to do so, because that's going to improve their healing potential. History of smoking, even if they told you that they quit 5 years ago, I sometimes I'm a little bit reluctant. Again, an element of denial exists in the neuropathic patients. So always get serum nicotine and cotinine level if there's any chance of them using tobacco products. We've talked about the labs, covered that up. Always ask for a history of infection or healed ulcer. A lot of these patients are not going to remember that they had an ulcer in their foot at one point in time. I want to exclude osteomyelitis or a remote history of infection. So always order CBC, ESR, and CRP. You always have to remember, in a neuropathic patient, the fracture can induce neuropathic changes. So redness and hyperemia on dependency that improves with elevation is a sign of acute neuropathic changes, but should not confuse us with infection. If you do have an acute neuropath, then definitely these are going to be, ooh, look at this slide. Then there's definitely going to be increased hyperemia, and this should not confuse us with infection. So how do I treat this? If it's classic clinically, and again, elevation reveals or relieves, the hyperemia, then this is an acute sarcopath, and I would keep them off of it for a longer period of time. Basics, imaging, MRI with contrast. If you have an access to an MRI machine with contrast, then definitely use it. Gadolinium is very important in excluding infection, and it can show intraosseous abscesses. This is a patient I got consulted on that had redness, hyperemia in the foot, and we got the MRI, and again, the MRI. Yes.
I'm sorry to interrupt. I don't think the slides are changing on our end.
Oh, really?
You just have to click the next. Yeah. Perfect.
Thank you. So again, MRI with contrast is still going to show you the differential between an infected and a non-infected foot. And the pattern has been very well described in the literature. I'm not going to go into details, but a diffuse uptake where the whole bone lights like a Christmas tree is going to be more indicative of neuropathic changes rather than acute infection. Now, if you are again, in an academic center with an access to a bone scanner, especially in the presence of metal in the patient's body where you can get an MRI, I would definitely go with what's called an indium labeled bone scan. Remember, again, the Charcot is a hyperperfused foot, so it's still going to be hot in the blood pool phase, but it's going to be cold or negative in the bone phase because, again, the bone is not infected. Whereas if there's an infection or any history of remote infection or osteo, then a bone scan is going to differentiate that. Especially, again, we saw some of our previous colleagues' x-rays with a lot of patients presenting with metal in their bodies. So this is when I go and order an indium bone scan. A CT with metal suppression or a regular CT is part of my bony workup because I want to look at the anatomy of the bones. I'm sure all of us order a CT as part of our routine workup. To sum up, diagnosis of osteomyelitis and neuropathic foot ulcers has shown that the dual isotope scans had sensitivities of up to 93% and a specificity of 83%. So it's pretty high, and it's a very good go-to investigation if you have a history of infection in that foot and you want to exclude it. We talked about the CT. It assesses the bone quality. It can detect occult or adjacent fractures or Charcopathic changes, the extent of comminution and concomitant arthritis that can actually guide you sometimes to perform a primary fusion in a neuropath. PET-CT is evolving. Unfortunately, here in the US, we've had trouble getting it approved through the insurance. It's definitely less invasive than the indium labeled bone scans and quicker than the MRIs. And I think if we wait on some studies that have come out, some of which are quoted here, there's going to be a major role for it. I'm sure my colleagues are going to hit on these basic principles, but with neuropaths, double the fixation, double the non-weight break time. Do not let the patient dictate their care. A lot of them are going to tell you, no, I want to walk on it, I can't, and it's yada, yada, yada. I think you have to cast them, keep them off of it for at least 3 months, especially in the presence of internal fixation. With external fixation and ring external fixators, we become a little bit more lenient. The Charcot group here in the US, there's a sort of a consensus of if you have a rigid external ring fixator, you can start weight bearing in 2 months instead of a full 3 months, just because of the rigidity of the frame and its ability to take weight. And the next, or the final tips and pearls, again, you have to operate ASAP to avoid soft tissue compromise, the principles of damage control, which I think most of us are going to be hitting on. Do remember that ankle and foot fractures in diabetics can provoke neuropathic joint changes. So if I have a patient that has an acute neuropathic change on top of an acute fracture, this is where the role of ring external fixators come in. In the old days, we put them in total contact casts and kept them non-weight bearing. But I think you can achieve an adequate reduction with a ring external fixator with an olive wire technique and put the external fixator on. It acts as a total contact cast on an external level. And it can calm down those neuropathic changes to a point where the foot becomes supple again. And then you can go back again and attend to these fractures with internal fixation and definitive management. And I think that's another dogma that's changing the neuropathic world. We talked about thinking of when to apply the external or hybrid external and internal fixation, so I'm not going to burden you with this. And finally, when do we do primary fusions? And I think, again, it's going to be hit on by the panel. For me, any evidence of dense neuropathy with dorsiflexion weakness or foot drop or a dense sensory loss is an indication for me to fuse this. It may be supple and not recognized. The presence of comminution definitely is an indication for a primary fusion. In my hands and in my humble experience, and it's anecdotal, and the faculty can pitch on it, a patient with a contralateral below knee amputation is not a good candidate for a primary fixation because no matter what, their prosthesis is not going to be able to take their body weight, especially if they're heavier. So with a contralateral below knee amputation, I have a very, very low threshold to fusing and not internally fixating. Finally, when you've done all of this, again, use intraoperatively the kitchen sink. Proximal tibial bone graft is always an asset for me. Use viable allogenous bone graft, use biologics. Just try and use everything on these patients because they are very, very difficult. We're wrapping up. If there's any history of infection, calcium sulfate beads are your friend. Be careful because they can cause yellowish discharge, which can confuse the internal medicine and infectious disease attendings, and they might think it's pus. So tell them that you have calcium sulfate beads there. We talked about calcium and vitamin D supplementation post-op. I'm coming to my end. While awaiting the intraoperative cultures in infected patients, before ordering an IND consult and ordering a PICC line, go ahead and order 2 sets of blood cultures before that. And before consulting plastics, they're going to take some time. Pre-order a CT angio on the bilateral lower extremities if you need soft tissue coverage to save yourself some time. When you've done all this workup and you're ready, brace for impact. You will see complications of your patients. This is a patient of mine, again, who had a contralateral below-knee amputation. I fixed her, and she came on her first post-op visit looking like this. So brace for your impact and get ready, and good luck managing all of these. And without, I don't know what happened, so I think some hieroglyphics have popped it on my images, but I'd like to thank you all, thank my family and my mentors and my colleagues. Chris, back to you.
Thank you so much, Amgad. That was awesome. Now we're going to hear from Dr. Bettin about midfoot trauma.
All right. Thanks, Chris. I'm Clayton Bettin from Campbell Clinic down in Memphis, Tennessee. I'm going to be talking a little bit about some midfoot things. These are tough patients with really tough problems. So they all have medical comorbidities. They all have poor bone quality. A lot of them are on dialysis. There's a high rate of complications no matter which way you go on these. Important things to remember is quality of life. Theirs is poor with Charcot. Data shows that it's very similar to that of patients with Parkinson's disease and chronic heart failure. Many of these patients with an ulcerative Charcot midfoot, when they come in, they've got a mortality approaching 50% at 5 years. So it's different than a regular non-neuropathic midfoot. There's no clear algorithms about how we should take care of these patients. And a lot of it's because this is very anecdotal medicine. Most of the studies out there are single surgeon studies with variable inclusion criteria. Some people tackle ulcerated things differently than others. Some people don't. Whether their A1Cs are controlled or not, all of these patients are very different. And then one of the things that we don't always talk about is just surgeons' preference and surgeon abilities. Mickey Penzer does a way better external fixator than I do. And so his outcomes are going to be different than mine. So at the end of the day, some of the things I'm going to talk about are where I've evolved over time, the system that I've found that's been working for me. You have to have a really high index of suspicion on these patients. I put this little text chat because this actually just happened last week. This is one of the reps for one of the surgical companies in my hometown here, who texted me, asking me if he could come into clinic as he was having some foot issues, and his primary care doctor took a X-ray and told him he had a Liz Frank. And they're like, hold on, what'd you do? Were you in a car accident or something? And he said it was low energy, wasn't having any problems. Like a high energy trauma. I'm like, well, were you standing when they took the X-rays? And he says, no. I'm like, okay, just hold on, come into clinic. Don't worry about this. We'll figure it out. And this is his X-ray. So it turns out the week before, he finds out he's got an A1C of 9, and he had no known issues before that. He hadn't really took care of himself. He's classic Memphis, a little overweight. But then we start asking, he's like, yeah, I've been having some numbness and tingling for a while, and it's been swelling for a couple of months. He was burying his head in the sand, and he's got a neuropathic midfoot. So when I'm looking at this, how I address this, I'm looking at Mills line. So a line drawn tangential from the navicular along the medial cuneiform. It should intersect the first metatarsal, and we can clearly see on the right foot, it does not do that. And then on the lateral, we see the break in the Meary's angle. So that's what I'm looking at initially on these X-rays. When I'm talking to the patient, how I'm thinking about addressing these, all of these are the things that will really vary what I'm going to do. So when's the last time your foot was normal? Somebody like this rep whose foot has just started falling apart over the past month or so, I'm going to be treating that very aggressively. In my mind, the bone is really not better, never going to be better than when it first starts falling apart. Somebody that comes in with a neuropathic midfoot and they say their foot's been like this for 5 years with no ulcers is going to get treated more with conservative footwear modifications. I'm curious about the A1C. For me, yes, typically below 8, the lower the better. But if I have somebody that has an acute Charcot and their A1C is 12, while I'm getting them into endocrine to get that addressed, I'm going to start checking fructosamines about every 3 to 4 weeks. because that's going to change much more quickly. And I think it's less about the A1C and more about what their sugars are at the time of surgery. So the fructosamine is changing about every month, and something where if I've got somebody with an elevated A1C, but we're in the correction mode and their fructosamines have normalized to an A1C below 8, I will jump on that sooner. Things like dialysis, other medical comorbidities, as was mentioned here by Amgad, if they've got an amputation on the other side, I'm going to be a lot more aggressive with this. And their baseline functional status. This is a normal person that's working a regular job. I'm going to do everything I can to get this reconstructed. If this is somebody that's a minimal ambulator at baseline, well, then I'm probably not going to be as aggressive. And if it's ulcerated, how long has that ulcer been there? If this is a fresh ulcer, it's something that I probably will ignore their A1C and I'm going to jump on it surgically, because by the time I've got it reconstructed and corrected, a lot of times that ulcer is going to close up. And if I just leave that ulcer there, I feel like I've got a much bigger chance of osteomyelitis starting to set in. So my goals of treatment, as Mickey Pinzer has pointed out, it's a stable plantigrade chewable foot that remains ulcer and infection free. I want to improve and maintain their quality of life. And it does not take 26 or 28 bones in the foot to do that. It needs to be a stable tripod. So my methods of fixation are internal fixation for the vast majority of these. I have done midfoot frames early in practice, and I just did not have good results with midfoot external fixation. I've had many, not many, but I've had at least 3 that I had done a midfoot frame and they did okay. And then they ulcerated again, and I had to go back and I revised it to internal fixation, and they've been doing well. So this is my algorithm for how I'm approaching this surgically. I break it into parts. They all have hindfoot equinus, so they all get a PERC TAL, followed by likely a tenotomy of their Achilles tendon in order to correct that hindfoot equinus. I've got a lazy S incision medially from the talar head over to the metatarsal shaft, and then an incision laterally over the sinus tarsi down to the 4th metatarsal. I tell my residents and fellows in these cases that Charcot rules apply. And what I mean by that is we're not spreading with tenotomies and looking for tiny little nerves. These people are neuropathic. This is knife through skin and then bovie down to bone. Full thickness flaps. I bovie right through the tibant. Anything else that's getting in my way, it's all just going to get stitched up at the end. But what matters is not just getting this x-ray of a stable tripod. It matters getting it quickly. And these are operations that we're usually closing by the time the tourniquet is coming down. And that matters. This same operation in 4 or 5 hours has got a much higher rate of infection. So recognizing the goals of our operation of being that stable plantigrade foot, it will speed us up. A lot of times, if it's a Chopart type Charcot, where it's occurred through the talinavicular calcanea cuboid, then that cuboid is going to come out. If there is no ulcer in the foot, the cuboid goes into a bone mill, and I'm going to mush it up for graft later. If it's something that's occurred through the navicular cuneiform joints, then sometimes it's going to be the cuneiforms that are going to come out. But I'm much more aggressive about excising bone in order to correct their deformity and then making a stable tripod of the foot that remains. I'm a fan of the internal fixation with the 7-2 beams. I put usually one in the 1st and the 4th and another one across the subtalar joint, and then plates. What I've shown here is a little tip for correcting some of that hindfoot equinus. After I've tenotomized the Achilles, I'll get underneath the talar head with a bone hook. I'll put a Chance pin into the back of the heel with the T-handled chuck and use that to crank the hindfoot out of equinus, and then pin that hindfoot up to the tibia while I build the rest of the foot up to that. Here we show the wires for my 1st and 4th going across the forefoot back into the hindfoot. And then we've placed our beams, and now we're placing a plate on top of it. I use a plating system that's all variable angle, which allows me a lot of ease for placing screws above and below these beams in order to support them. I place vancomycin powder in all of these patients and a little bit of thoughtful prayer. I try to keep them off of it for 10 weeks or so, but in my experience with these neuropathic patients, they're all walking on it. If they don't walk on it, they're going to fall. And so I found fallacy in my initial dogma of thinking that they were going to not walk on it and placing a little less hardware. Now I've gone to placing more hardware in order to protect the patient from themselves. I still tell them to not walk on it, but I recognize that they are going to. So these are then some examples. This is the patient that I first showed here, internal fixation, first, fourth subtalar joint. Somebody like this, another example of excising the cuneiforms. In this situation, the talonavicular joint was well preserved, so I was able to prep that and maintain that, but I've excised the cuneiforms in the cuboid in order to correct my deformity. Another patient here, when I see this, where it's occurred through the tarsometatarsal joints, the cuneiforms in the cuboid are going to come out in order for me to correct my deformity. And without an ulcer, those will get bone milled up to create graft to then pack into any voids that are remaining. In this situation, where I've got something where it's not really the joints being dislocated, but more of a chronic deformity, this is where I still will go to a biplanar wedge. The way I like to do it is I will place K-wires along the AP view of where I'm planning to do my cuts, and then I bend the wire, and then as I will rotate that wire in the lateral view so that the wire is pointing along the axis of the talus and the first metatarsal. And then when I come in with my saw, I know that I'm going to keep that saw perpendicular to that axis. And that's been a way that I've found to do this midfoot wedge, and then stabilize it the same with bolts and beams and plates after that. If the lateral column is not involved, then I don't take it down, but I will still go to a beaming system along the medial side as shown here. And if the lateral side is just starting to subluxate, but the bone quality is still good, there are options on the market where you can apply some plates along the fourth and fifth with screws then that go back into that calcaneus. I have started placing screws across the subtalar joint kind of preemptively. I did have one patient initially that then failed at their subtalar joint when I hadn't done that. I haven't found yet where I think it's made a big difference in terms of stiffening up the foot too much or causing any other problems, but time will tell with that. If it's a patient where things have fallen apart relatively recently, they may not need beams, but they're going to need more hardware. I'm a big fan of nitinol for a lot of my fixation, but not in my Charcot patients. The Charcot patient with their often renal osteodystrophy or other poor bone quality, nitinol staples just are not good options. So something where I can get plates on every one of these joints, I have found to be appropriate. And it's often the more metal, more better. When I have something like this where it's failed at the talonavicular joint, you'll see that I'm often spanning onto the other joints of the foot for stability, but I'm not prepping all of these joints. In this situation, I would absolutely prep the talonavicular, but I'm not going to necessarily take down the navicular cuneiform and the first TMT, but I will span onto that just to get a more rigid construct and apply dual plating. Here's another example then of somebody that has fallen apart with dual plates and has now done pretty well. So what have I learned from taking care of a lot of these patients? These are tough problems, but man, are these patients incredibly grateful. I do think supratentorial neuropathy is a real thing. I will find that I have to tell these patients the same thing over and over and over, and recognize that when they're not following my instructions for not walking on it, it's not always them just being not compliant. It's either they didn't quite understand, they forgot from their neuropathy, or they just physically can't not walk on it. First, do no harm does not mean don't operate. A lot of times the most conservative thing is aggressive surgery in these patients. If their A1C is controlled and their foot has fallen apart, I do think I operate on it much more quickly, and I've had a better outcome with regards to their quality of life. This surgery is fun. I really enjoy this type of operation much more than the forefoot surgery where I see my recurrences come back and I feel like a bad surgeon every time. And a lot of these patients, there's a good chance if I don't do anything, they're going to end up with an amputation. And so I do find this surgery to be very grateful, but expectation management is absolutely critical. These patients have to understand what odds they're up against and recognize that below knee amputations can do pretty well. And so I will sometimes see these patients that a local podiatrist may have been nursing an ulcer with wound care when they clearly have a neuropathic midfoot deformity that's not going to go away. And, don't waste your time in life. Life is short. Again, a lot of them have a 5-year, 50% mortality. Try something different, improve their quality of life, and move along. So thank you for the opportunity. That's my talk, and then I'll hand it off to, I think, Dr. Scott.
Awesome.
Thank you so much. Next, we'll hear from Dan.
Awesome. So thanks, Chris and Selene, both for having me on here, and for the rest of the panel. I'll continue these nice, easy cases with talking about neuropathic ankle fractures. Here we are, some of my disclosures. So if you're anything like me, this is how some of my patients look, which certainly tends to be a tough patient population. With ankle fractures in general, right, we all know that we've got to obtain and maintain a stable mortise. That still applies for these patients, and that's the number one goal. Certainly articular reduction is a secondary goal, and as we'll talk about, sometimes you're going to be fusing these people anyway. So how do we accomplish these goals? We have a lot of different tips and tricks, right? We have plates and screws, which we're all used to using. You can do minimally invasive plating. That is an option. Fibular nails can have some indications in these folks. Certainly hindfoot nailing or ankle arthrodesis can be very helpful, or circular frames, as Amgad mentioned, and I'll touch on some more. So we know these patients are really challenging and don't do well, right? So this is a paper out of FAI in 2000. Retrospective review, a bunch of ankle fractures. They have both a mix of op and non-op, but if you look at the diabetics, and especially the 12 that had neuropathy, they had 8 patients that developed infections out of the 12, 5 that even underwent casting, closed management, and still got infections. Not surprisingly, they found that patients with a higher A1C did worse. No surprise there. So what about non-operative management, right? These patients are sick. They're sometimes non-compliant. They have a million comorbidities. Can we just get by without surgery? So this is another paper out of FAI from 2017. They had 28 patients with diabetes and unstable ankle fractures. All were close reduced to less than 1 millimeter of talar shift, so pretty well reduced. 20 were managed conservatively, 8 went on to ORIF. They had a 75% complication rate in the non-op group. And when you look at these complications, these are not minor complications, right? So over half lost reduction, a third went on to get Charcot of their ankle, 25% of non-operative patients got wounds, 10% had deep infections, 25 went on to need more surgery, right? So statistically significantly, the non-operative patients did worse than the operative, even though they all had problems. In general, as Amgad mentioned, so a couple sort of rule of thumb things, right? So in general, double your fixation, double your non-weight bearing time. We've probably all heard this before. Certainly, as Amgad mentioned much more thoroughly than I did, you got to know the A1C on these people. You really want to know if they smoke, and you really want to have some idea of, do you think this patient will be compliant when you tell them to stay off of it? Because most of them will not, as Dr. Bettin mentioned. In general, in my hands, the more risk factors I have for infection, the more I'm going to be thinking about alternate fixation techniques instead of your standard plate and screws. So for plate fixation, we've all probably heard about the traditional approach, right? Rigid fixation, multiple quadricortical syndesmotic screws. As you can see here, right? These patients have poor bone. They're not always the most compliant. Obviously, they can't feel their foot normally. And so you want to do whatever you can to maximize your fixation. Quadricortical syndesmotic screws can certainly help. Now, the downside of plates and screws, as we all know, is you need a pretty big exposure to put on some of these things, right? And certainly the bigger incision you make on these folks, the higher risk you're going to have of complications. So alternative fixation techniques, and thank you, Sam Adams, for some of these slides. So fibular nailing can be helpful. Hindfoot nails can be helpful. External fixation, right? So what are the benefits of some of these things? At least in my hands, if I'm doing internal fixation plus a circular frame, I will let these patients walk a heck of a lot sooner on it because they're probably going to walk anyway. And you might be able to get by with smaller incisions, less fixation with some of these different techniques than you might with plates and screws. So what is the benefit of using a fibular nail? So there is some data that shows in non-neuropathic patients that there are less complications with fibular nails. This was a study you can see highlighted here. Basically, they had in older patients, randomized control trial, and they had a lot less wound complications in fibular nails compared to ORIF, right? Not a huge surprise, but no difference in clinical outcomes, no difference in patient satisfaction, right? So there may be some benefit. This is one case you can see of a neuropathic patient, so A1C of 9.4. She has this, wide medial clear space in this Weber B. Of course, she has dense peripheral neuropathy. Of course, she tells me she's going to walk on it right away. So you can see what my approach was, which was plates and screws combined with a circular fixator to allow her to walk early. She didn't go on to Charcot. She did go on not to heal her lateral wound. So at 5 months, I had to go in and take her plate out, but at least that finally healed. So, a good outcome, but you're certainly not going to get a good outcome every time, no matter what you do. Hindfoot nailing is certainly a good option, right? So these hindfoot nails are load sharing devices, which is great for this patient population and these patients that tend to have very poor bone. Certainly your fixation is mostly percutaneous, which is very attractive in these people who are trying to minimize their incisions. And you can combine this with either open joint prep, minimally invasive joint prep, or even no joint prep. Personally, I tend to prep a joint if I'm going to shove a nail across it, but this can be a great time to use an MIS burr or even a scope if you're really going to torture yourself. I find hindfoot nails most useful in very complicated fracture patterns. So a lot of comminution, really bad pilons, very low demand or sick patients, right? This is a good way to get them up and moving with more rigid fixation as opposed to plates and screws or fibular nails in somebody who the loss of angular subtalar motion may not make as big of a difference for them. And certainly this is somebody that I would feel a little more comfortable weight bearing earlier compared to your standard plates and screws ankle fracture. There certainly is data to support this. So this is a study out of Injury that looked at 16 patients, older patients in general, not all neuropathic, but they all got hindfoot nails for sort of more complicated ankle fractures. And they did all get back to their baseline level of mobility. And this is with over 1 year follow-up. So again, this can be useful certainly in your elderly geriatric patient population. Certainly some of these neuropaths fall into that group. This is another group. So this is a randomized control trial. This was also an Injury. 70-year-old patients with bimal's, trimal's, fracture dislocations. They were randomized to a hindfoot nail versus plate and screws. And they found that the hindfoot nails were allowed to immediately weight bear, or I'm sorry, they let the hindfoot nails immediately weight bear as opposed to 6 weeks of non-weight bearing with the plates and screws. And they essentially had similar outcomes, even including some patient-reported outcome measures. And they had fewer complications with the hindfoot nails, right? So there are definitely some benefits of this, of potentially maybe letting people weight bear earlier. Again, I'm certain, with the neuropath, that's a huge challenge, but at the very least, it is potentially a more stable construct. This is one case example of a good time for a hindfoot nail. Again, thank you, Sam Adams, for this presentation. So 71-year-old female, diabetes, neuropathy, non-compliant, lots of medical problems. This is somebody who a nice salvage option can be that hindfoot nail and let this person walk a little bit sooner, especially in somebody that you might not otherwise want to put a frame in. These are also patients that you might consider adding even additional cannulated screws or other fixation because they're going to put some weight on it right away. Circular fixators. I'm a huge fan of circular fixators. They're very useful, as Amgad said, in the setting of active infection or ulceration. That's certainly my go-to in that patient population. I will allow these people to weight bear for transfers right away, and I'll let them walk fully whenever the sutures come out, assuming there's internal fixation. So I find it very helpful to protect my internal fixation in people that I know are otherwise going to stress it, which is certainly most neuropaths. It does tend to be a pretty durable construct. Of course, with frames, you do get complications. So pin site infections are going to be probably the most common. If you look at the literature, that can be at least 20% of your cases. The good thing is the vast majority will get better with oral antibiotics. Certainly, when a wire starts to get loose, it's more likely to get infected. If you've got just one wire that gets infected, those usually can be managed by pulling a wire in clinic, which is not such a big deal. If you've got multiple really badly infected wires, that can be returned to the OR. Likewise, wire breakage or loosening are also very common. If it's one wire, usually you can pull it. A lot of times I like to build redundancy into my frames for this reason. Certainly, if you get loosening or breakage of multiple wires, that usually means you're going back to the OR for a frame revision and making some adjustments. Here's another case, courtesy of Sam Adams, with somebody that was treated just with a circular frame. So this is another diabetic neuropath, a lot of medical problems you can see here. And really, even more impressively, is their skin, right? Certainly, you look at this patient, and that's not an ankle that you're very excited about putting an incision on anywhere, right? So these can be a really nice time to use an isolated fixator, right? You can either use olive wires to reduce your fracture and apply some compression, or you can mount your frame and then either adjust, get the reduction with your frame, or reduce things first closed, pin it, and then mount your static frame. Either way, it's a very nice way to obtain some fixation in a patient that you otherwise would be very concerned about making any larger incisions or doing anything more to reduce the fracture. And you can see this is sort of the outcome after the frame came off. Certainly a planograde foot, which is the goal, maybe not going to win the award for most beautiful x-ray, but most of the time these patients aren't going to get you that anyway. So what is my approach? How do I boil this down? How do I decide between all this different stuff, right? So for me, ORIF has the advantage of you're going to get your best mortise reduction, and obviously you're going to maintain their range of motion. The disadvantage is with plates and screws, I'm the most worried about things failing, and you're probably going to need a larger exposure. Hindfoot nail is going to give you probably the best control of the mortise because obviously you've got a big rod going from the calcaneus to the tibia that's going to be real stable. But you're going to lose your ankle and subtalar motion, and certainly somebody who's more active, that's a big trade-off. External fixation is definitely your friend for infection or for somebody who's really, really going to stress your fixation. If you're doing isolated external fixer, that's probably your least control of the mortise. This is certainly something that patients do not like and are going to complain about. And frames are typically be on a long time. So you've got to have somebody who can come back and see you often so that when you get these pin site complications, these infections, they can come back and find you. This is not a good option for the patient who lives 6 hours away and can't attend follow-up visits. So my approach, younger, more compliant patients, simpler fractures, typically you're going to get ORIF. If I can get by with a fibular nail with syndesmotic fixation, I will do it, but certainly they're going to need a lot of fixation. Older patients, sicker patients, lower demand patients, increasing fracture complexity. Again, pilons are a lot of articular comminution. I'm going to lean towards a fusion. Most of the time that's going to be with a hindfoot nail. Most of the time I'm going to try to do some MIS joint prep if I can. And then in the non-compliant patients, which is many of these people, anyone with an active ulcer, anyone who's got a very high A1C, big time smoker, but is able to come back for multiple follow-up visits is going to be getting a circular frame plus or minus some internal fixation versus a fusion. So takeaways, what do we take from this gobbledygook talk? Neuropathic fractures are hard, right? I think we all know this, but it bears saying it's hard for all of us. There's no easy right answer, right? There's no great literature to guide our decision making. These patients are high risk of complications, whether you operate on them or don't operate on them. You do have to individualize this for the patient, for the fracture, for all the different comorbidities that Amgad and Clayton have talked about. The double your fixation, double your non-weight bearing time is a good rule of thumb. And these are definitely the people that you want to think about alternative techniques other than just your standard plates and screws. So with that, here are my references, and I'll turn things over to Ben.
Thanks, Danny. We're going to have Dr. Jackson go on next. I'm going to pass the computer over to him. He's been quietly sitting here waiting to talk.
Outstanding. Well, thank you guys very much. Thanks for letting me be involved with this really outstanding panel to be able to talk. So I'm going to share with you guys really 3 different cases, what I'm calling the good, the bad, and the ugliest thing possible. So we're going to start off light and then progress. And I'm going to agree with a lot of the things that some of the previous folks have said. So we're going to start a case with a 75-year-old female, has diabetes. Neuropathy is not profound, though. Mild renal disease, does have a palpable pulse, but is a limited community ambulator. And I think what you're going to see through these cases, with at least examples I have compared with some that Dr. Scott had and others, is you can treat these a lot of different ways. So this is the injury film of this particular patient, really more of a bimolecular type of ankle fracture, a lower demand patient, but not a really severe fracture pattern. In this patient, I like to treat them with really would be my standard construct for a regular ankle fracture, non-neuropathic person. Her neuropathy was not severe. She had a good pulse. We made just a lateral medial-based incision. I stressed it. I did not feel like her syndesmosis was unstable. And so this is one that I would say, fortunately, and we did 6 weeks of non-weight bearing, kind of a standard ankle fracture construct. And this is her final x-rays roughly about 9 months out from her injury. Fortunately, she healed well, has a reduced ankle mortise, no significant post-traumatic arthritis, and had a really fairly uneventful outcome for this particular patient. So I think there have been a few cases that we've shown that have been disasters, and don't worry, I'm getting to those. But sometimes it really is just an ankle fracture, and we want to keep that in mind. We want to keep the principles in mind as well of length, rotation, and alignment with a minimal soft tissue dissection, I think is really important as well. So I think keeping those principles in mind with these patients are really important. And thinking about that first, I think is key as well. The next case I'm going to show you actually started with some of my trauma partners. This patient has diabetes with pretty significant peripheral neuropathy. However, she's only 43 years old and does have some high blood pressure and high cholesterol as well. However, this person was a fairly active person. She was a community ambulator without any assisted devices. She drove, she worked, and all those type things. And this was her ankle fracture. Pretty significant ankle fracture there. A lot of displacement. I would say that's basically trimalleolar ankle fracture dislocation. Not the largest soft tissue envelope that you've ever seen, but not the smallest either. But a pretty severe fracture pattern and pretty significant displacement there. I think there was some concern. There was maybe some even impaction on the lateral portion of the tibial profile. You can see the fibula there is at least in 3 separate pieces for sure, and a significant dislocation event. Again, I did not take care of this patient. Initially, my trauma partner selected for this particular type of fixation, which I would call interesting. So what they did was they did not prepare the joint, and they placed these 3 cannulated screws across a 43-year-old's joint that are all 6'5" screws. And as I think the folks on this particular conference would understand well, if you put 3 6'5" screws across your joint, that does not lead for a lot of normal joint left. And they really essentially did a TTC attempted fusion with no joint preparation and across both joints. And the concern was because of infection that they did this. So they really did this through 3 small incisions. And unfortunately, despite that, it still got infected. So that was concerning. So she developed a draining wound with active gross purulence from around one of the medial screws. And this was within the first 6 weeks. And so then I got the pleasure of taking care of them. Had a conversation with some of my trauma colleagues about I generally wouldn't recommend putting 3 6'5" screws across somebody's joint that you're not going to prep, because I think the healing rate of that is low. And to Dr. Scott's talk that he had earlier, I think if you elect to use a TTC nail, which is not something that I do commonly, but I think there is an indication for it in the right patient and the right fracture pattern. The difference in that construct and the construct that you just saw with my orthopedic trauma colleagues is one's a load sharing construct versus a load bearing construct. So with a TTC fusion nail, that's a load sharing construct where their force is going to be transmitted from the calcaneus and from those interlocking screws to the proximal tibia, where the other construct is really not that. So they really can't weight bear on that quickly. The joints are not prepped, and you've really ruined the joints, but you didn't prep them for fusion. So that is going to go on to a symptomatic, essentially non-union and back to a regular joint. So, which is even further complicated by infection. So what I like to do in this particular patient was to take out her hardware. We put a circular frame on her so we could get her some antibiotics. We tried to do the best reduction that we possibly could, but unfortunately, because it was weeks out, because of the infection, there had been some loss of fixation of the hardware due to the infection. So we were able to get her in this particular position. She did ultimately heal her infection. Believe it or not, she did not get any pen site infections during this. And this is actually about a year out. So believe it or not, because of her neuropathy, she was not very symptomatic, despite the fact her joints looked terrible. There's a fully weight-bearing x-ray, as you can see, and roughly about a year out. Again, the good news is that she was able to heal her infection. She was able to heal her fractures, and she has a reduced joint. Now, it remains to be seen if she's going to end up needing something like a TTC fusion nail down the road. But I'm just pleased she has no internal fixation, and she's able to mobilize and doesn't have a current infection. So I think the principles from my standpoint with this, that was kind of what I mentioned there. She just saw some swelling. Is if you have an infection, a diabetic patient, you need to do your best to be able to get rid of the hardware. I think a circular frame is very helpful for this. And then you need to get a multidisciplinary team involved. We got our infectious disease folks involved, get them started on IV antibiotics. And I think cleaning out the infection thoroughly. I heard earlier from Dr. Bettin, his frequent use of vancomycin powder. I think that there's definitely some indication in the literature for that. I think if you have a high concern for infection, that's important, or the patient actually has an active infection, that can be really important as well. So that was the bad, and now we've got the really ugly here. So this is a 55-year-old diabetic male who has severe neuropathy bilaterally. He actually had trauma 1 year ago. And back to Dr. Scott's article that he mentioned about the complications with non-operative management of ankle fractures. He had an ankle fracture managed by an outside physician non-operatively, and then he developed a worsening deformity. That physician allowed that deformity to progress over a period of 9 months. So ultimately, he presented to me looking like this. He had a prior fifth-rate amputation and was ultimately walking on the lateral aspect of his foot and of his ankle. So those are his foot x-rays. This is an ankle x-ray. And to complicate matters even worse, he absolutely unequivocally refused to have an amputation. So he had an open wound on the lateral aspect of his foot as well as the lateral aspect of his lateral malleolus, and was essentially walking on the lateral aspect of his ankle. I think an amputation in this patient is absolutely a reasonable option, and despite myself as well as a second opinion and infectious disease recommending an amputation, he refused. So we did go down a limb salvage pathway with this particular patient. So what we did for him was we initially placed him in a ring fixer. The goal of that was simply to stabilize him. Because this had been a 1 year from his fracture and 9 months of a progressive deformity, I was really unable to reduce it at that time. You can see by the staples there on the picture on your right, I did make an incision. I did try and clean out some of his areas of osteomyelitis. I did try and close the wound that he had to the best of my ability to do that. Placed vancomycin powder, obtained cultures, and then sent him over to our infectious disease specialist. We did attempt to correct him somewhat, which was very, very challenging to do. You'll also note in the right-hand picture, again, this medial malleolus is out to lunch and essentially non-existent virtually. But we did improve his alignment somewhat. The main thing was we were able to get him at least an ulcer-free foot. It was not plantigrade at this point, as you can see on the left, but we were able to improve his position, get him without an active ulceration, get him on the right antibiotics, get him off antibiotics, and to the point that he did not have any type of draining wound, off antibiotics, and a regular CRP. You can see we did get him a little bit better position. I apologize, it's a little bit darker on your image there, but the image on the left does show him in a better position there with the ring fixer, closer to a plantigrade position, and we did correct some of the midfoot and forefoot alignment there. But now obviously needs some stability because he really doesn't have much of a functional ankle joint at all because his talus was rotated about 90 degrees. So next thing we did for this particular patient was give him a frame holiday. And so you can notice also he had very strong bone, strong enough that I broke off one of his proximal bolts that we had in his frame. And we left him in this position without any fixation. So better than he was before, but clearly not great. So he had the frame off. We gave him a frame holiday, again, made sure he didn't have an infection to the best of our ability to do so, and then attempted to nail him. This is a very interesting case because basically in order to prep his ankle joint, I dislocated his talus, and that was very easy to do. Actually reamed through his talus, but you will see that the talus was not so connected to the TTC fusion, unfortunately, and just squirted out the side. And that's just because there was hardly any talus there. I was not very optimistic, but hoping that he was actually going to be able to heal the talus to the lateral tibia and then to the lateral calcaneus. I didn't have any great luck with that. This is a little bit of the construct he had, and this is not immediate post-op film. You can see it didn't really get much better with time. He did develop some heterotopic bone and healed some of the lateral tibia to sort of that talus there, but not really much healing from the talus to the calcaneus. He wasn't a better plantigrade position. Unfortunately, as this course is carried on with him, this you'll notice is a 2-year later radiograph. His renal disease has gotten even worse. He's now currently on dialysis. But he's been able to ambulate on his foot. He simply wears a walking boot all the time. And believe it or not, the guy goes to work despite it looking like this, kind of amazing. But I would definitely say it is not healed. We ultimately were able to get him because he had such loosening of the TTC nail in his calcaneus. We were ultimately able to get that removed from him. And this is where he currently sits. Shockingly, he is able to ambulate on this in essentially a crow boot. He doesn't have an ulcer. His foot's in a plantigrade position. He is able to work. And although I would not call this a radiographic success by any stretch of the imagination, I would say that functionally he's doing okay at this point. I'm concerned his story is not yet done being written, however, though, with a foot that looks like this, but he is able to ambulate with that crow boot on. So what I think the principles are here. So this is 4 years after initial presentation to me, 5 years after his initial trauma. The first thing is, I think in a diabetic patient, as Dr. Scott mentioned, and the literature would support, it's okay to operate on these folks. I think oftentimes My trauma colleagues included are scared to operate on these folks and do some kind of limited fixation that doesn't have much stability. And as I sometimes say, is a bit of fuzzy thinking about how to do this. You need to restore length, rotation, alignment with minimal soft tissue dissection. So I think that that's important. He has a superficial ulcer. So he was able to ambulate. He wears a walking boot. But he does have an ulcer on the other side from all his weight bearing. Unfortunately, he still needs dialysis and needs a kidney transplant, but can't because of his ulcer on his other side, and he is still refusing an amp. So what are the principles? Some of these really don't go well. Some of these are very ugly, and you want to get at least the person with a stable post to bear weight through. And sometimes patients refuse an amputation, even if that is the best option for him. So in conclusion, I think you don't want to forget your ankle fracture principles, even if these folks have diabetes. There's a challenging orthopedic problem, and they have challenging medical conditions as well. And all these patients, you really get to know them well. Unfortunately, they often need more fixation, as has been mentioned, and you really want to get a multidisciplinary team involved. And I think that's critical to the success of these patients.
All right, Ben, thank you so much. I'm just going to act as a floating voice right now. Ben's right next to me. I guess Amgad, and then we'll go on with Clayton and Danny. What is your role of treating an acute fracture in a neuropathic patient, knowing how badly it can go? Do you stabilize it then and there, or do you try to optimize their situation in terms of nutritional status, A1C, things like that, and then understand that you're going to have to go back and correct some deformity later? What are your thoughts, Amgad?
Optimizing is fixing them. The studies have shown, as I told you, even if it's an angry Charcot, that flaring A1C, the once you stabilize that foot and calm down the Charcot, you're on the road to success while maintaining the optimization clinically. So again, if it's florid with ulcers, just like all the panelists said, I think I'd bring external fixator as my go-to. If the A1C is not wild and the soft tissue sleeve is relatively good, then I would go for internal fixation or hybrid.
Yeah, for me, I think when you say if it's a fracture, I'm kind of looking at it like every fracture. If it's an ankle fracture, I'm going to fix it. I'm going to load them up with syndesmotic screws. But even if their A1C is high, I'm going to treat that fracture. But expectation management of them understanding they may get an infection. Well, if they get an infection, I'm going to wash them out. I'm going to suppress them until they're healed, and then I'm going to take their hardware out. And then I'll do the Charcot type procedure if needed down the road. But what I'm not going to do, and I think the main take home is what we should not be doing is just putting these into casts and thinking that that's just going to be benign. You can't leave that unstable trimal ankle fracture splinted or casted in just that. They're going to ulcerate. They're going to have a problem. So getting them stable, getting them fixed, and managing their comorbidities. But in the setting of an acute fracture, it's going to get acute treatment from me.
You had your hand raised?
Yeah, I have a question for Clayton before I forget. So the fructosamine has really evolved right now. I haven't used it. Do you have a cutoff, or are you waiting for it to normalize when you're following it through?
No, I don't wait for it to normalize. Literally what I do is if you Google fructosamine to A1C conversion, there's a formula. And I want to say it's like 0.017 times the fructosamine plus 1.6. That calculates the A1C equivalent. So I look at that. And when that calculated A1C is under 8, that's when I'm going to jump on it.
Great. Danny, you have a minute to answer that question.
To me, it's a little different. Ankle fracture versus Liz Frank. If it's an unstable ankle fracture, I'm going after it. Kind of like Amgad said, frame and/or internal fixation. Midfoot, it depends on sort of the degree of deformity. If it's a not that badly displaced Liz Frank, I'm a little more permissive as far as giving it a little bit of time to optimize. If it's badly displaced and it looks like it's going to ulcerate, I'm going to go after it right away because I would much rather get it before it ulcerates than after.
Hey guys, I didn't get a chance to welcome you guys onto the 24-hour town hall, but thank you so much for all that insight and great cases. Also wanted to thank Arthrex for sponsoring this hour, but again, sorry I wasn't able to welcome you guys on.
No, thank you,
Cool.
Dr. Parekh. And it's 5 p.m. our time, so that means it's up for the next group. Sudhir.
This is the last hour. You guys were second to last. Well, thanks, guys.